Okay, so today we're going to talk about cardiovascular drugs and drugs we can use to help with cardiovascular disease. So, the primary function of the cardiovascular system is to maintain effective circulating volume in order to maintain adequate tissue perfusion. And by maintaining the normal tissue perfusion, we can maintain organ function and sustain life. When we have heart disease, that can be caused by infection, inflammatory issues, structural degenerative, even sometimes genetic disorders. Progression to heart disease can develop into heart failure, the inability of the heart to pump efficiently, and the inability of the heart to pump a sufficient amount of blood to meet the metabolic demands of the body. So there are 4 stages of cardiac disease. Stage 1 is when we see there's no heart murmur, or there may be a slight heart murmur, and at this point we don't really need any treatment. Stage 2, there may be a cough, and this is where we start to restrict sodium diet. We may need to use a dilator or a bronchodilator. Stage 3, we have a cough, reduced exercise. We may start to need to use a positive ionotropic drug or positive ionotrope. We may need to use some ACE inhibitors as well as some sympathomimetics. And then stage 4, this is when we start to see dyspnea at rest. They are needing some oxygen to supplement them. They may need some sedatives because they are visually, they are upset due to the fact that they cannot breathe efficiently. So when we're treating cardiac disease, we want to try to control rhythm disturbances that can happen, and we can use drugs to help with that. We can also want to make sure that we are maintaining or increasing cardiac output, and we can do this by using drugs like positive ionotropes to help increase the strength of the contraction. We may need to use some vasodilators to help decrease preload, or some arterial dilators to help decrease afterload. We need to use diuretics as well as salt restriction to help relieve fluid accumulations. We'll want to use a bronchodilator to help increase oxygen blood flow, and we may need some ancillary treatments towards the end, like narcotics and sedatives. Because of the lack of oxygen, they can become stressed and overwhelmed. So cardiac drugs tend to have a low therapeutic index and margin of safety, and we've talked about therapeutic index before as well as margin of safety. So this would be where you need to really make sure that you're monitoring things like the heart rate and the rhythm of the patient, the blood pressure. You'll want to make sure you're doing EKGs to see if there's any arrhythmias. Monitor chest x-rays to see if they're getting fluid in their lungs or the size of the heart. Want to check mucous membrane as well as cap refill time, and this is going to show us how well they are perfusing. We may need to do some blood pressure, make sure we're checking their MAP, and we want to check their peripheral pulses, especially the femoral artery. We want to make sure that it's not weak or thready, and that it is pumping as within rhythm of the heart. So the first drug we're going to talk about are positive ionotropes, and these are primarily used in management of heart failure, and these help to increase systolic function. They increase the myocardial contractility by either increasing the intracellular calcium concentrations or by increasing the intracellular affinity of the cardiac contractile mechanism for calcium, and this works by not increasing intracellular calcium concentrations. So basically, this helps to just improve contractility. Studies showing whether these drugs work are pretty lacking, but they are generally used to treat cardiac heart failure, as well congestive heart failure, as well as atrial arrhythmias. We use these kind of as a last-ditch effort, and it's usually near the end of the treatable cardiac disease. We do have concerns when we're using these drugs. And that's because they do increase the oxygen demand of the cardiac muscle. So the heart needs more oxygen to function. It also can damage the contractility apparatus of the heart, so it doesn't contract as well as we like if they were to stop these drugs. And it does have a tendency to cause arrhythmias. And these arrhythmias need to be treated, but generally we treat arrhythmias in the hospital. So we have for many, many hundreds of years been using cardiac glycosides, which are positive ionotropes. And these, again, inhibit the sodium-potassium pump, and they increase the intercellular calcium fibers to contract efficiently. The side effects of these drugs are anorexia, vomiting, diarrhea, as well as cardiac arrhythmias. And the drugs we use are Digoxin as well as Digoxin. So Digoxin lasts longer, where Digoxin can tend to have more cumulative effects. These are toxic, so you do need to monitor these drugs quite closely. So Digoxin, we use this to treat CHF as well as supraventricular tachyarrhythmias. It is considered less than that potent of other positive ionotropes like dopamine or dobutamine. And we use it mainly to decrease the ventricular response rates to SVT, such as atrial fibrillation. It does improve contractility, and it does decrease signs of dyspnea. So digoxin is not lipid soluble. It binds to the skeletal muscle, and it doesn't distribute well if they have ascites. The bioavailability is 60 to 75% when we're using the elixir, and it is primarily excreted through the kidneys. It does have a neurotherapeutic range, and adverse effects are associated with myocardial toxicity and some gastrointestinal upset. You may also see some renal toxicity as well as some electrolyte alterations. So catecholamines or sympathomimetics, these are drugs that work to stimulate beta-1 receptors. They increase the force and the rate of the contraction. They increase blood pressure. They also can increase blood glucose. They do have short half-life, so they use them in short-term management of heart failure cases. So some examples of catecholamines are DEN, and that's an acronym you can remember it by. DEN, D is in dopamine. This helps to increase renal blood flow. It also helps with supporting the blood pressure. You can use this for acute heart failure. It works on both the alpha-1 and beta-1 as well as the dopamine receptors. It is a vasopressor, so we can use it with circulatory shock, and it's used as a CRI with a short half-life. Then we have E, which is epinephrine, and epinephrine is used to activate all adrenergic receptors, both A and alpha and beta. It helps to increase heart rate. It increases cardiac output, peripheral cutaneous vasoconstriction, skeletal muscle vasodilation. It can also be used for treatment in cardiac resuscitation as well as anaphylactic shock. And then you have N, which is norepinephrine, and basically norepinephrine, it works with the alpha adrenergic receptors, and it's used primarily for its vasopressor effects, and it increases blood pressure as well as having some ionotropic effects. So antiarrhythmic drugs, we rarely use these in practice, but when we do use them, we help to restore SA and AV node pathways. They use these in resuscitation situations, and generally they're hooked up to an EKG when they're using them. There is some. So the causes of arrhythmias can be caused by hypoxia, electrolyte imbalances, catecholamines, even those catecholamines released by the body, and this is important to remember, particularly when we're using anesthesia with feral or fractious animals. Drugs can also cause arrhythmias like digitalis, thiobarbiturates, inhalant anesthetics like xylazine, or inhalant anesthetics like isoflurane, and xylazine, which is an alpha-2 agonist. Cardiac trauma as well as disease can alter the cardiac cells, and this can cause arrhythmias also. So some antiarrhythmic drug examples that we might see are procainamide and lidocaine. They use procainamide as an antiarrhythmic agent. It prolongs the refractory period, and that's the period of time when the cell cannot be stimulated, and it slows conduction velocity to both normal and abnormal cardiac tissues. They use this to treat SVT as well as atrial fibrillation and ventricular tachyarrhythmias, and it comes in injectable form. It is compatible with sodium chlorides, water for injection. You can use it with dobutamine, lidocaine, or vipramil. It has a short half-life of about 3 hours, and it's metabolized through the liver. You may see some GI effects as well as hypotension if you administer it too quickly, as well, and AV block. Lidocaine is the other type of antiarrhythmic. It is used to block sodium channels and delay conduction velocity to the primarily abnormal tissues. We use this to treat ventricular tachyarrhythmias. It usually has little effect on the atrial conduction, so we don't really use it for atrial fibrillation. It's effective for treating ventricular tachycardia as well as that is associated with digitalis toxicity, so maybe an animal that has gotten into some digitalis or foxglove. We do need to make sure that we're using a continuous read EKG when we're using these drugs, because we want to make sure that we are monitoring their heart rate, their heart rhythm. So the next drug we're going to talk about are adrenergic beta blockers, and these prevent the release of norepinephrine as well as epinephrine. And what beta blockers do is, so beta blockers, they block the catecholamine stimulation of cardiac beta 1 adrenergic receptors. They slow the conduction velocity through the AV node, and they are useful in slowing down the ventricular response rate to SVTs. They do possess a negative ionotrope, negative chronotropic, and positive allotropic properties. Negative ionotropism is not really beneficial to patients who already suffer from systolic dysfunction. So the main drugs that we use are propranolol and Adenol, as well as metoprolol. And propranolol, it's used for hypertrophic cardiomyopathy. It reduces heart rate, cardiac output, blood pressure, and that's where it comes from the beta blocker. It does undergo for extensive first pass effect through the liver, so we need to keep that in mind when we are using it. It can potentiate bronchospasms, and it can increase the peripheral vascular resistance. So we don't want to use these drugs in animals that have chronic lower airway disease, diabetes mellitus, or hyperkalemia. Atenolol, this is primarily a beta-1 antagonistic effect, and it has minimal effects on the beta-2. It decreases cardiac rate, it decreases cardiac output, and it slows AV conduction velocity. And they use this to treat hypertrophic cardiomyopathy in cats that have prolonged diastole, which is the other half of your blood pressure equation. We can use it to treat VPCs, and atenolol is usually administered only in the oral formation. So vasodilators are used to help with management of heart failure and cardiovascular disease by reducing preload and afterload. It also helps to manage systemic hypertension, and then that aids in improving the patient's hemodynamic parameters to help by reducing edema as well as increasing forward output. So hydralazine is an arterial dilator. It's used for chronic heart failure due to mitral valve insufficiency, and it's normally used with left-sided heart failure. It is potent and a specific arterial vasodilator. It significantly reduces the afterload and it increases the forward flow and decrease backward flow. It can decrease systemic vascular resistance by about 50%. Onset of action, oral administration is 30 to 60 minutes and it lasts about 12 hours. Some adverse effects of using hydralazine is hypotension, reflexive tachycardia, anorexia, vomiting, as well as sodium and water retention. So we'll want to make sure that we use a diuretic when we're using this drug. Nitroprusside is a balanced vasodilator, and it's used for short-term management of congestive heart failure, usually secondary to mitral valve regurgitation. It can also be used for a hypertensive crisis. It has a rapid onset and short duration of action, and therefore it's usually administered as a CRI. Blood pressure will usually return to pretreatment levels within 1 to 10 minutes following the stoppage of the CRI. It is sensitive to light, heat, and moisture, so you want to make sure that you are protecting it from light if you're using it in if you're using it in a fluid bag. So you'll want to make sure that you only mix it with D5W. Don't want to add any other drugs to the bag, and you may want to put a cover on the bag of fluid to protect it from the light. It seems like when you put it into plastic containers exposed to fluorescent lighting, that it deteriorates much more rapidly. It can produce profound hypotension, which necessitates continuously monitoring the blood pressure, and excessive doses can cause hepatic or renal insufficiency, and it can cause cyanide as well as thiocyanatic toxicity. So you'll want to watch for signs of toxicity, which would be stupor, delirium, seizures, depression, and metabolic acidosis. So really, we only use nitroprusside in an ICU setting. So prazosin, this is used to manage congestive heart failure as well as systemic or pulmonary hypertension, and this is usually unrelated. You may use it for management of functional urethral obstruction in cats and dogs. It's a selective alpha-1 blocker, so it causes balanced vasodilation. It's used to reduce edema, and it increases forward flow and cardiac output by reducing preload and afterload. The main adverse effects of the drug are syncope, which is secondary to hypertension. It can cause anorexia, vomiting, and diarrhea. If you use this with other types of drugs that have hypertensive effects, you may potentiate that hypotension. It is highly protein bound, so it can displace other drugs that are highly protein bound, like nonsteroidal anti-inflammatories. The last drug that we're going to talk about is nitroglycerin, and nitrates are basically metabolized into nitric oxide, and they relax the vascular smooth muscle, and they produce primarily vein dilation. The net effects of this is redistribution of blood from the central to peripheral vasculature, and it reduces in preload, and this can cause edema. So there is a phenomenon called nitrate tolerance, and they can develop an insensitivity or loss of responsiveness to this drug, and why this happens we don't know. So nitroglycerin It's primarily used as an adjunct treatment of congestive heart failure, pulmonary edema, and systemic hypertension. It decreases preload, it reduces myocardial oxygen consumption and workload, and it increases coronary perfusion. It's an ineffective agent for treating heart failure, and it's not recommended to be the sole agent. We use this topically. The duration of action can be from 1 hour to the onset is 1 hour, and the duration of action is 2 to 12 hours. You need to store it in an airtight container. The injectable solution absorbs into plastic tubing, so we want to be aware of that, and it can cause severe hypertension and skin irritations. The thing about nitroglycerin ointment is it can also be used to treat laminitis in horses. So if you're using nitroglycerin in your clinic, you want to make sure that you wear gloves because it can cause headaches to you if you get it onto your skin. You'll want to rotate application sites. Usually they use it in a hairless area inside the ear. Don't pet the animal where the application site is. Here's my funny drawing for you that I can't get to work here. So you'll want to put a piece of tape and you want to write nitro on it. Make sure you're wearing gloves when you're doing this. And if there is a rash that starts to appear in that area, make sure you let the veterinarian know. So some other vasodilator examples are angiotensin converter enzyme inhibitors, or ACE inhibitors. And ACE inhibitors, they are a vital component of RAS, which is renin-angiotensin-aldosterone system. And this is what prevents it converts angiotensin 1 into angiotensin 2, and this is primarily in the lungs. So angiotensin 2 is a potent vasopressor, and it also stimulates the aldosterone release from the adrenal cortex. And this is what stimulates thirst, stimulates the ADH, which is antidiuretic hormone release, and it facilitates sympathetic tone as well as triggering myocardial remodeling. So as the direct effect of inhibition of angiotensin 2, ACE inhibitors produce balanced vasodilation, and they modulate the RAAS system. And since the arterial dilatory effects are considered mild when we compare these to other dilators, ACE inhibitors are most beneficial in their ability to modulate the RAS. Their combined vasodilator effect and the ability to decrease sodium renal and water absorption makes them more advantageous when we use these to treat heart failure because they reduce both preload and afterload. So enalapril, this is a drug that is used to convert that from the active form of enalaprylate in the liver. It's primarily used for long-term treatment of heart failure and hypertension. Its bioavailability is about 60%, and onset of action is 4 to 6 hours, and duration is about 12 to 14 hours. Benzopril is similar to enalapril. It is converted into a more active form of benzoprilate in the liver. It has decreased renal metabolism, but it has the same ability to induce renal failure, and it has the ability to reduce renal failure. And so calcium channel blockers. Calcium is vital for many of our physiological functions. And in the cardiovascular system, it regulates the impulse formation and conduction. It also helps with vascular tone and contractility of the myocardium. In regulating the impulse formation and conduction, calcium channel blockers slow the L-type calcium channels on the cell membranes and prevent the influx of the calcium into the cell. So they slow the conduction through the synovial, atrial, and the AV nodes, and they prolong AV node refractory period. So like beta blockers, calcium channel blockers have negative ionotropic effect, so they decrease myocardial contractility. They're negative conotropic, so they decrease heart rate, and they are a positive lusiotropic, which means they improve myocardial relaxation. Their primary use is for treating supraventricular tachycardias. So basically, they also cause the peripheral arteries to dilate, and they decrease the workload. And the side effects of these drugs can be hypotension as well as anorexia. So some of the calcium channel blockers are Vepramil, and this primarily affects the cardiac calcium channels, and it slows AV conduction. It increases the refractory period, and it decreases atomicity. So basically, it kind of slows down the heartbeat. It's used for treatment of SVT, or supraventricular tachycardia, as well as atrial fibrillation in dogs. Some of the adverse effects of Vepramil is the depressed myocardial contractility, hypotension, bradycardia. It also can cause tachycardia. It can exacerbate chronic heart failure or congestive heart failure. And it can do AV block as well as pulmonary edema. So we want to avoid this drug with patients that already have pre-existing hypotension, have sick sinus syndrome, which has to do with the heart and the beating of the heart, and second or third degree AV block. Another drug that you may see used is Cardiozem or Diltazem. They have similar actions on the AV conduction as the Vepramil. They do have more vasodilatory effects. They decrease the heart rate. They prolong the diastolic fill time, and they induce vasodilation. It decreases afterload. When you have therapeutic doses, it has minimal effects on cardiac contractility. So they use this mainly for CVT, or supraventricular tachycardia, atrial fibrillation in dogs, as well as hypertrophic cardiomyopathy in cats. They may also use it to help treat hypertension. You want to make sure that you're using this drug in caution when you are administering it with a beta blocker, because it can have that negative ionotropic effect. Bradycardia is the most common side effect that's seen in dogs, where vomiting is the most common side effect we see in cats. Some other side effects may include GI distress, hypotension, and heart block.